Hello and welcome to a new lecture in forensic medicine and clinical toxicology. Today we will be talking about head injuries. My name is Dr. Maha Farid and I am a lecturer at the Department of Forensic Medicine and Clinical Toxicology at Helwani University. These are the learning objectives of this lecture. Please be aware that we will be dividing the topic into two parts and this is only part one. Starting with the epidemiology of head injuries. As you can see, this slide shows an article that is estimating the global incidence of traumatic brain injury. It states that 69 million individuals are estimated to suffer from traumatic brain injuries from all causes each year. And when it comes to low to medium income countries, the proportion of traumatic brain injuries is caused mainly by road traffic accidents. When it comes to classifications of head injuries, we have multiple classifications. The first classification would be the anatomical classification, depending on the anatomical site of the injury, and we will discuss this in details. This is the one we will be using to classify the injuries of head injuries in this lecture. Second one would include closed or open. It describes the injury as a closed or open. Closed head injuries are also known as non-penetrating injuries where there are no skull fracture or penetration of the dura mater. Example for that will be blunt traumas. Open head injuries are also known as penetrating head injuries, where there is disruption of the cranial vault and exposure of the brain tissue to the exterior. Examples for this would be firearm wounds, cut wounds, motor vehicle injuries, or occupational accidents. In forensic medicine, we care about the manner of the injury or the death if it is a fatal injury. So we describe it as accidental, homicidal, or suicidal. Accidental happens when there is no intention to hurt someone. It happens when the injury happens by chance or by an accident. It is known as an accidental injury. Homicidal, when the injury is inflicted by a person against another person with intention, so this is called homicidal. Suicidal is when the injury is caused by one person against himself with the intention to cause death. When it comes to describe an injury in a forensic report, you need to keep in mind the items listed on this slide and try to find answers to these questions. So what is the causative instrument? Is it a blunt instrument or a sharp-edged instrument? What is the extent of the force? Is it heavy or is it light? The direction of the force and the site of application, which describes the relationship between the assailant and the victim in most of the times. The anatomical site of the injury, and usually when we describe an anatomical site, we need to use landmarks, anatomical landmarks as midlines, mid-axillary lines, the nose, the ears. You need to describe the distance between the injury and a common fixed anatomical landmark. Also, when you describe the injury, you need to include the type of the injury, the shape, is it circular or spindle shaped, number of injuries, the edges, how they look, sharp, regular or irregular edges, the angles, the hair ends if it is covered by hair. When you study the lecture of wounds, you should know all these items in details, but I just wanted to include this in this lecture because we will be talking about different wounds and that in the head injuries, and this is like a systematic thinking to help you understand how we describe injuries. For the sake of this lecture, we will be using the anatomical classification of head injuries. We will start by studying the injuries of the scalp, injuries of the bone, which include skull fractures, injuries of the brain and the meninges, which is known as the intracranial injuries. Injuries of the scalp. This is a brief reminder of the anatomy of the scalp. The scalp is an abbreviation for skin. S is for the skin. C is for the connective tissue or superficial fascia. A is for the aponeurosis, which is the epicranial aponeurosis containing the occipitofrontalis muscles. L stands for loose connective tissue, and P is for the periosteum. Types of scalp injuries include abrasions, contusions, contused wounds, also known as lacerated wounds, cut wounds, firearm injuries, physical or thermal injuries. And for the sake of this lecture, we'll be discussing only the first four types. Firearms and physical injuries will be discussed in separate lectures. The first kind of scalp injuries we'll discuss here is abrasions, known in Arabic as tahagat. This happens when the force is enough to cause destruction of the superficial layer of the skin, the epidermis. This kind of force usually is dragging or friction force. In Arabic, abrasions are known as tahagat, اللي هي الخربشة يعني. Sometimes the force causes contusions or كدمات, which happens when there is extravasation of blood in the underlying subcutaneous tissues. The kind of force in both injuries is a blunt force, but it is not enough, or it's not heavy to cause disruption of the whole thickness of the skin. So there is no open wounds in here. But sometimes when it is severe, it causes an underlying brain damage, and this could be detected by brain imaging, as in CT scan. Lacerated wounds, known in Arabic الجروح المتهتكة. This is a very common type of scalp injuries. It is caused by heavy blunt force. The force is heavy enough to cause disruption of the whole thickness of the skin of the scalp, and there is active bleeding. Sometimes it is confused with cut wounds, and therefore we need to have to examine the wound with a hand lens. We look for irregular bruised edges, and the hair ends will be crushed because it is not cut by sharp object. There are some tissue bridges crossing between the edges of the wound. Sometimes it is also accompanied by heavy injury in the brain itself, and CT scan is a must to exclude traumatic brain injuries. This type is the cut or incised wounds, and it is also one of the common types of scalp injuries. It is caused by heavy object, but it has a sharp edge, causing a clear cut in the skin of the scalp. Examples for such instruments are the axe, known in Arabic as الفاس, or the chopper, known in Arabic اللي هو الساطور. As I mentioned before, it might be confused with lacerated wounds. Therefore, hand lens examination is required. This kind of wound has clear edges, and the hair ends are sharp with sharp angles because it's cut by a sharp object. Also, it is associated with severe and profuse bleeding. Sometimes it leads to shock. Complications of scalp injuries. Of course, number one would be hemorrhage. Scalp is a very rich organ with blood supply, so it's very common to have profuse bleeding that may lead to shock if it's not stopped. Also, the fibrous tissue in the scalp structure causes traction on the blood vessels, which interferes with vasoconstrictions and the stoppage of the bleeding. The second complication would be septic infection, especially cellulitis, tetanus, and erysipelas. Also, because of the presence of the emissionary veins, leads to spread of infection, causing either meningitis, encephalitis, brain abscess, or cavernous sinus thrombosis. This illustration shows you the connection between the veins in the scalp and the cavernous sinus that is very close to the brain inside the skull cavity, the cranial cavity, and this makes the spread of infection very easily from the scalp to the in cavernous sinuses, leading to cavernous sinus thrombosis and encephalitis. Different types of meningitis. We need to differentiate between different types of meningitis, whether it is traumatic in origin or caused by meningococcal meningitis, or as a complication of ear infection, specifically otitis media. So in case of traumatic meningitis, usually there is a history of trauma, and you can find a skull fracture or an external injury, any kind of anywhere in the skull. If there is a pus collection, it's beneath the scalp wound, very close to the site of injury. And if we use bacterial culture for diagnosis, we will find the staphylococcus or streptococcus as common organisms for this kind of infection. On the other hand, meningococcal meningitis is caused, there will be history of sore throat, epidemic meningitis in the community. There will be symptoms of neck rigidity. The patient will complain of neck rigidity. The skull will show no injuries. You will not find any evidence of trauma. And if there is pus collection, it will be usually in the independent part of the skull, which is the base of the skull, by the effect of gravity. Bacterial culture will reveal meningococci as a causative organism. When it comes to otitis media complications, meningitis following otitis media, there will be history of ear infection, and usually it is located close to the ears and the temporal bone, and it is associated with temporal bone necrosis. If we use bacterial culture to diagnose the infection, we will find the organism is very similar to the organism causing the ear infection, otitis media. Now we will be discussing different types of scalp hematoma. Sometimes the injury is so severe that it causes a collection of blood under the scalp. This illustration shows the different locations of different types of scalp hematomas that we will be discussing now in this table. The first one is the subcutaneous hematoma, which is located between the skin and the aponeurosis. Usually it is small in size because it is limited by the dense fibrous strands of the aponeurosis of the skin. This this kind of hematoma usually firm, circumscribed, but painful. But it is painful. The subgaleal hematoma is a collection of blood below the aponeurosis. Usually it is large in size, limited by the attachment of the occipitofrontalis muscle. It is soft and diffuse, but it is less painful. The subperiosteal hematoma is the one forming below the periosteum of the skull bone, so it takes the shape of the underlying skull bone. Usually it is limited by the suture lines. Example for this is a cephalohematoma that is formed usually in the head of the newborns. Now we'll be moving to discuss skull fractures. Skull fractures, so injuries of the skull is known as skull fractures. Usually it is associated with brain damage because when the force is heavy enough to cause disruption of the bone vault of the skull, it is heavy to cause brain damage. Any skull fracture is considered as a dangerous wound because it needs more than 3 weeks to heal. Sometimes it is complicated by permanent infirmity. The type of the skull fracture depends on many factors. First, the site of the impact, whether it is the vault of the skull or the base of the skull. The force, whether it is heavy force or a light force. Also the striking surface area, is it a wide surface area or a small localized surface area as in case of a hammer? The edge of the striking surface, is it a sharp edge as in cases of choppers and axe, or is it like a blunt like a stone, or as in case of falling from height? Also the presence of head support makes a difference. When a person receives a blow while the head is supported by the floor, for example, if he lying down, it will give an injury that is different from a person receiving a blow in the face in the standing position. Also, the presence or absence of head protection, as in case of wearing helmets in motorcycle accidents. And finally, the elasticity of the skull. Skull of infants and young children is more elastic than the skull of adults, where it is bony in structure. For example, when the force of the blow is small and it is applied for a short time, and the skull is somewhat elastic, as in case of children, most probably no fracture will happen. On the other hand, if there is an extensive blow is applied for a sufficient time, the skull will be fractured. The type of the fracture differs if it is the head supported or not. If the applied force is great and the striking surface area is very narrow, as in case of bullet injuries, the result is a clean hole fracture, as in cases of firearm fractures. Bigger surface, a somewhat bigger striking surface with a less force of momentum will result in a localized depressed fracture, and we will discuss this in details. Also, the effect of the blow usually more pronounced when the head is supported, as I mentioned. For example, the victim is asleep on the ground because the head will be crushed between two forces, the force of the blow and the force of the support of the floor. All these factors change the type of the fractures that happens in the skull. The first type is the fissure fracture. Usually, these kind of fractures are caused by flat, heavy objects. It may occur alone or complicating other types. It starts at a point of the impact and extends in a direction parallel to the line of the force application. Fissures may be branched and may run into sutures, causing their separation. Multiple blows lead to multiple fissures, and in this case we may find a complete fissure and an interrupted one. As you can see in this picture, this one is a complete fissure, and this fissure is interrupted by the other one. And if we find such finding, we know that this one, the complete fissure, happened first, and then the interrupted fissure happened next. And this will help to identify the location of the assailant. Because the fissure, the second one will not interrupt, will be stopped by the first one and will not cross to the other side of the skull. Anatomically, vault fractures happens to the frontal, parietal, or occipital bones, and basal fractures happen in the base of the skull, because it is a weaker part of the skull where it is interrupted by many foramina. These are some pictures showing some fissure fractures. For example, on this slide, you can see that the fracture is extending from the frontal bone till the occipital bone. Okay, in this picture, I want you to look into this fracture where it is running into the coronal suture, causing separation of the skull bones. When it is running into a suture, a fracture is called diastatic fracture. Okay, here also it shows that it is running into the coronal suture, causing separation of the frontal bone from the parietal bone. This is a branched fracture. The second fracture here is interrupted or stopped by the site of the first fracture, and it did not cross to the other side of the skull bone. When a fracture is extending from one side till the other, as in showing here in this picture, it is called as hinge fracture. Basal skull fracture most probably also is fissure fractures. One of them is known as the ring fracture. This describes a circular fracture that happens around the foramen magnum. The ring fracture happens when a person falls from height on his buttocks or his heels, or he falls upside down and is hit on his skull in an erect position. So what happens is the person falls down, and the reaction of the force is transmitted through the vertebral column and hits against the base of the skull, causing a ring fracture around the foramen magnum. Here also it describes the hinge fracture. As I mentioned, it extends between two sides of the skull, separating the skull into two halves. It is very common with motorcycle or car accidents. The manifestations of basal skull fractures depend on the location of the fracture. For example, if the fracture happened in the anterior fossa, as in cases of blow to the forehead, or as an extension from a frontal bone fracture, usually the patient suffers from bilateral black eyes. Sometimes it is called raccoon eyes. There will be cerebrospinal rhinorrhea, where the cerebrospinal fluid is coming from the nose. Epistaxis, which means bleeding nose. When it comes to cranial nerve affection, the olfactory nerve, the first cranial nerve, will be distorted, leading to anosmia. The oculomotor, abducent, and trochlear nerves will lead to impaired eye movement and dilated pupils. If the fracture happened in the middle fossa, as in case of a blow to the chin, when a person is playing boxing, or is it as an extension from temporal bone fracture, the signs will show battle sign. Battle sign is a hematoma over the mastoid bone on the side of the trauma. Also, cerebrospinal fluid otorrhea, CSF otorrhea, where the cerebrospinal fluid will be leaking from the ear. Also, bleeding from the ear, or it may be accompanied with cerebrospinal fluid rhinorrhea or epistaxis. Cranial nerve affection will include affection of the fifth cranial nerve, leading to paralysis of the muscles of mastication and impaired face sensation, affected the trigeminal nerve. The seventh cranial nerve, facial nerve, will lead to facial palsy. The vestibulocochlear nerve, the eighth nerve, will lead to deafness or impaired hearing. If the trauma happened in the posterior fossa, as in case on falling on the occiput or extension from blow to the occipital bone or occipital bone fracture, a hematoma will be formed in the muscles of the back of the neck, and cranial nerves affection will include the vagus nerve and the glossopharyngeal nerve, leading to dysphagia, dysphonia, and dyspnea. Another fracture type is the depressed fracture. Usually it is caused by a heavy blunt force with a localized striking surface. An example for that would be a hammer. Usually the fracture occurs at the site of the force impact, and it takes the shape of the striking surface. The outer table of the skull will be depressed, but the inner table of the skull will be comminuted and fragmented, and it may lead to brain damage because the inner table of the skull is only supported by the soft brain tissue. If a depressed fracture happened in an infant, usually the skull is elastic, and it forms a kind of fracture called the pond fracture, where there is only an indentation of the outer table, but there is nothing. There is no actual fracture in the skull bones. Cut skull fractures. These happen by heavy, sharp instruments, as the chopper or an axe. It occurs at the site of application of the force. The shape is usually a triangle. Bone defect. There is a bone defect, and the base is usually towards the sign of the assailant. It indicates the site of the application of the force. The edges are usually sharp, regular, and straight. Comminuted fracture. This happens by severe injury by a heavy blunt force. It falls from the example for that is falling from a great height or a run over accidents. The bone is fragmented into small pieces, and maybe it is associated with depressed fracture. Most of the time it is also associated with depressed fractures. In this picture you can see all kinds of fractures we discussed in this lecture. From the left to the right, this is a comminuted fracture here, where the bone is fragmented into small pieces. This is a diastatic fracture, where it runs into the suture, causing separation of the two bones. This is a linear fracture. This is a depressed fracture, where there's a small indentation in the vault of the skull. If we look at the base of the skull, we can see here the ring fracture around the foramen magnum. And this is a hinge fracture, an example of a hinge fracture where it extends from one side to the other side of the skull, separating the base into two different halves. Healing of skull fractures. Usually fissure fractures, when the edges are close, they heal completely. But if the edges are separated, a process called ivory formation, where smoothing of the edges happen with time. If there is a bone defect, as in case of cut fractures, in the vault, healing occurs by membrane formation. Usually it starts within 3 months and extends up to 12 months. The membrane at the beginning is very thin, and then it thickens gradually with time. Also, sometimes septic complications happen, and it interferes with the complete healing process of the fracture and may lead to death. The post-mortem appearance of an infected fracture of the skull will show erosion of the edge of the fracture, and this indicates that a healing process has started, but it is not completed before the death of the victim. With this, we reach the end of part 1 of this lecture, and see you in the next part. Thank you.